all. This meeting being recorded. Okay, thank you. So my name is Char Rodriguez. You know about that. I'm director of the Family Medicine Education Research Group, and it's my pleasure to welcome you today. All very well-known faces. This is the special Family Medicine Education Research Group research seminar. We organized, for the moment, we have organized 2 over the academic year. We gave one in September last year, and this semester we have the pleasure to welcome our colleague Roland Grad. I think all of you know Roland Grad, but for people who are perhaps outside the department, Roland Grad is first and foremost a full-time family physician. He's also associate professor in the department and is the director of our clinician scholar program and a founding member of the FMER. So he will talk to you today about one of the latest latest studies that he has undertaken with a big research team. And just 2 more words about the procedure. As usual, Roland will be talking about his project over 35 minutes. If you have any question to ask during the presentation, please write it up on the chat, and Anik and I will manage that. Once Roland finishes the presentation, I will give you the word according to the order of statements included in the chat, and then by 1:30 we will wrap. Okay with you about that? So please, Roland, the Zoom floor is yours. Go ahead, please.
Thanks so much, Sharon. Can you see my slides? Not yet? All right, let me try and share. And you see them now? Great. Okay, thank you. I'll try and make it in presentation mode. So we're going to talk about this. Does spaced education, not space like NASA, but spaced, and we'll talk about that in a minute, improve clinical knowledge among family medicine residents, a cluster randomized controlled trial. This is open access publication just out last month in Advances in Health Sciences Education. So you can all jump in there and have a look at the paper at any time. Lots of co-authors, 12 sites in this RCT. And I wanted to really acknowledge the tremendous contribution that I got from these sites. But here at McGill, I specifically want to thank Tibor for his excellent work. Actually, I started working with Tibor on this when he was still in Melbourne. So that goes back a few years. Teresa Rudkin helped me here at McGill. Pearson Wu, who is actually a McGill medical student, now a family medicine resident, helped me a great deal with the analysis of the data. And I just want to say thanks to the leadership of the department for allowing me the time to do this kind of work. It's no small feat to do this kind of research. So as Cheryl mentioned, I am a practicing family doctor. I see people of all ages, babies to the very elderly. And I do it right next door at the Herzl Clinic. I'm also a member of the Canadian Task Force on Preventive Healthcare, so I contribute to guidelines. And in that role, I'm a volunteer supported by a McGill salary for travel and accommodation only by the Public Health Agency of Canada. I get a small consulting fee for Naître et Grandir to help Pierre Pluy with some of his work. And importantly, I do get an annual grant, unrestricted educational grant from Jewel, which is a CMA company. And I mentioned this work. It's actually money I get for something called the POEMS Continuing Education Program for family doctors, and actually for all doctors who are members of the CMA. I mention it because the money I got from Jewel actually supported this trial. That's how I was able to fund it. Since Charo knows that we tried in 2016 to get CIHR funding, and we wanted to do some qualitative work alongside the trial, but that was not funded. So I show you this assembly line because sometimes it feels a little bit that way. In my work as a teacher of family medicine residents, I work next door, and I told you how I'm a clinician and I'm involved in academic activities through the department, but I'm also a teacher, and I teach the future family doctors who come through the Herzl Clinic, medical students and family doctors. And there's so many of them that it sometimes feels like I'm on an assembly line. We get 23 residents a year, every year, 23 new residents in family medicine, not to mention medical students. So the whole enterprise of producing doctors is a pretty big enterprise. And I wanted to mention this because I think it's relevant to the background of what we're going to be talking about today. Talking about how to produce the best possible family doctors we can through residency training. And this is, you know, a typical residence schedule. It's over 2 years. So they have their shortest residency program in the Western world. You know, the UK and the US do it in 3 years. We do it in 2 in Canada. We put work hour restrictions, of course, because now when you're post-call, you can only do 16 hours, which is a lot different from the 30 to 36 hours we used to do straight. So there's fewer hours available than before to actually train our residents. And they change often every month or two, they're doing a different rotation. So that's the context. And at the end of their 2 years, they write this thing called the certification examination in family medicine, and they must pass this exam in order to get a license to practice. There's a written and an oral component, and this is routinely collected. The college runs this for decades now, and they collect the examination scores. So we have all this data on all these people coming through. And I trained in research in the 1990s. Actually, I became a family doctor in the 1980s, and then I started working with an epidemiologist here at McGill named Robin Tamblin. And so Robin was interested in training and the relationship between residency training and practice, what doctors do once they enter medical practice. And she wrote this paper, I think, around 1994. Is the public being protected? And, you know, she basically says here, you know, the purpose of our residency program and these certification exams is to prevent unqualified individuals from entering medical practice. So the idea here is that, you know, we've got to do something to keep quality standards up, obviously. And the examination is part of that quality assessment process. She went on to study the association between the licensing examination scores of the College of Family Physicians of Canada and what doctors actually did in practice when they graduated for the first number of years of their practice. And this is a publication in JAMA. She actually published 2 articles in JAMA on this, 1998 and 2002. And what she showed were impressive statistical associations between scores on the exam and measures of quality. For example, if a doctor scored higher, he was less likely to prescribe a contraindicated drug to an elderly patient in his practice. So, you know, that tells you that there's observational evidence to support the idea that we should try to train residents as best as we can to score as high as possible as they can on their exam. So in that context, we have seen the emergence of something called learning science over the last few years. This is something developed by cognitive psychologists, okay? And there's even a web page that you can go to, and it's called thelearningscientist.org. And they talk about strategies for effective learning. So just quickly, okay, if you don't mind, how many of you could put an example of a strategy for learning science into the chat box? Take 10 seconds. Can you name one strategy from the field of learning science to improve learning? Oh, by the way, spaced education is cheating, so you can't do that. So you know what? We'll come back to that. But on the slide here.
But there are people, Roland, writing. Learning engagement, group discussion, interactive, problem-based learning, engagement.
Interesting. Well, look, I'm no expert in learning science, but the According to the learning scientists, spaced practice, retrieval practice, interleaving, elaboration, these are examples of what they call strategies for effective learning. So there is proof from the field of cognitive psychology. So in my simple mind, when I was thinking about how to do a better job in terms of training residents and how to improve them in their performance, I thought about, this exam that they're writing, and they spend a lot of time focused on the exam, especially in the few months leading up to it. They tend to study something once, they wait a little while, and then they study it again. And then there's some delay in time before they have their final exam. And that's the sort of typical scenario where they cram to study it once, study it again, wait a little while, take the final exam, okay? But there is something called spaced learning as a learning strategy to improve learning. And actually, recently, 2019, there was a scoping review published on the topic. And what Aliki Thomas and her colleagues tried to do here was to say, how is spaced learning defined and applied? And in health professions education in particular. And no surprise, they did find many different terms that were used to describe this concept in their scoping review. And they came up with their own definition at the end of their work. They said this: spaced learning involves educational encounters that are devoted to the same material and distributed over a number of periods, separated by an interstudy interval with a specified learning outcome, like an exam, after a specified retention interval. So that was their definition. And it's different from something called, just mass learning, where you just kind of cram at the end. And the theory is that educational encounters that are spaced improve learning retention when compared with massed learning of the same information. And this has been described as the spacing effect. Now, there's an additional component of spaced education, and that's the testing effect. And that is that just testing yourself helps you to retrieve information that you've previously learned and then retain it better. So there's an effect of learning caused by testing yourself. So I stole this kind of thing off the internet here, but it's kind of nice to look at. And it's a curve that describes the retention of something that you've learned and how that drops over time. And this is the famous forgetting curve. The forgetting curve was actually described in the 19th century by a guy named Ebbinghaus. And so there's nothing new here. We all know this. But the idea with spaced education is that if you repeat and then test yourself, you can actually do it once, you can do it again, you can do it a third time, and it's supposed to flatten out that forgetting curve. So at the end, you get better long-term retention of information. Okay, that's the theory. The question is, does it work? And when I was preparing to do this trial, I actually looked very hard for evidence in the family medicine context. And this was, around 2015, 2016. And what I was able to find were some very small studies that were done in a subspecialty focused area like urology. So it was in 2019 that this systematic review came out, showing only 4 studies done in primary healthcare. 2 of them were small RCTs, and they focused on practicing doctors. Okay, so not doctors in training. And there were positive results in these 2 RCTs in primary care, showing, for example, that if you did spaced education around PSA screening for prostate cancer, you could increase the number of what they call appropriate PSA test orders. So very focused outcome in a very, very focused context. I did look carefully for any research in spaced education in a family medicine residency context. I found nothing in family medicine. There were 4 small studies in internal medicine, oncology, OB, GYN, and I think surgery. And again, these were, in very, very focused outcomes, subspecialty areas, and nothing in family medicine. So my thinking was, look, we have a very short residency. We have many, we're super broad field. Spaced education, yeah, there's signals that it could work. It does work in subspecialty context. Would it work in a family medicine context? In a training family medicine context? And that was the rationale for this study. The other piece behind this is this incredible tool that we all have in our hands, and that's the handheld computer. Now we have these portable handheld devices that are literally data collection devices, so that if you want to track what somebody does, all you need is to get access to them through the handheld device. And here's a review published in as a best evidence in medical education review, which is sort of like the Cochrane review of medical education. And it talks about how we should develop educational practices to make best use of mobile devices and look at how they focus. How do these devices support learning? Okay, so the path to an RCT is not a straightforward or simple one. You don't wake up one morning and say you're going to do an RCT. But I did have this idea that I could do one on the concept of whether spaced education would improve knowledge in the family medicine residency. So we went through 3 steps. We went through like a usability study of a mobile app. We then did a feasibility study to see if the residents would actually use the app, would they pay attention to alerts in the app? And then we tried to do a definitive study, which was the actual trial that I'm going to tell you about. And my research question was as follows. Does spaced education compared to no spaced education improve clinical knowledge in the residency context? So I developed, for the usability study, I actually developed my own app. And the app was based on the 99 priority topics in family medicine. And I worked with a Master of Arts student in educational psychology, Diana Ramos, who ended up becoming a family medicine resident after her master's in educational psychology. So she and I built this app, and we tested it in terms of its usability. And Peter then took Diana on as a graduate student for her PhD and helped her write this up and published our work in a journal called Perspectives in Medical Education. And one of the interesting findings out of the usability study was that, we could track what residents actually did. And here's a chart of their monthly use of the app. And what you'll see is that initially there's a kind of high level of use in October, and then it drops down rather sharply. And then about 2 or 3 months before the exam, it picks up quite a bit, as you would expect. People are getting ready for their exams. And then after the exam's over, it drops off again. No surprise. But it shows that we can track 2 things. Residents were interested in the app, and we can track their use of the app. Okay, so that's the usability study. They gave us some other feedback, but we don't have time to get into that now. I went on to a controlled study, if you will, where I compared 2 sites, McGill and McMaster. McMaster residents got the app with alerts turned on, and McGill residents got the app with no alerts. Okay. And we published that as a feasibility study. We determined that outside of McGill, at McMaster, yes, residents were very interested in this app to help them to prepare for their exam. And they would actually pay attention to the alerts. So here we tracked the number of pages viewed in the app, comparing McMaster in blue with McGill in red. And what you'll see again is that there's this really tremendous novelty effect at the beginning. Like, here's my toy, I'm going to play with it a lot, and I really like it. And then it drops down. And we're not here, this is all first year, so we're not looking at them preparing for the exam. But importantly, Charo, we also interviewed these residents. And what we found when we interviewed them was that there was a problem of alert fatigue, that people were saying, I get a lot of alerts, and this was in 2016. And so when we tried to nuance that a bit, it turned out that those who were less enthusiastic about the app in general also felt more fatigue. So fatigue was sort of something perceived by people who were less enthusiastic with the idea of using an app. But we also learned that you needed to have testing, that this app that we had developed, it had alerts, it had content, but it did not have test questions to really test their knowledge. And as you'll recall, spaced education requires repetition and testing. So at that point, we published our findings here. We knew that if we were going to develop the trial, we needed to have a better product, a better app. And there was something out there. There was something developing at Western University. Just as I'm getting ready to do the trial, a colleague at Western launches an app to help residents prepare for their exam. And it's extremely popular. And there's no way I can compete with him, okay? And I knew that I would need the residents of Canada to get behind this if we were to have adequate statistical power to find small effects in knowledge. So I just cold called him up and I said, look, I'm interested in doing this research. What do you think? And he was delighted. And we ended up collaborating on this trial together. So that was a kind of a very positive experience for me. We did a cluster randomized trial because we obviously can't randomize individuals to an app or not, because those residents who had the app would talk to the residents who didn't have the app, and that would be contamination of the intervention. So we clustered the randomization by school. Our intervention was this app developed at Western University by Dan Leger called the Family Medicine Study Guide. And we developed a special version of the app for the intervention group. That special version contained alerts to encourage them to read one case a week. And this is what a case looks like. On the left, you see case number 10. It's like a long paragraph, a clinical case. And then there's about 5 questions per case. And in the app, there's 75 cases. Okay. So they would go through the case, answer the question, and then they'd click next and they would see the answer right away. So they would get immediate answer feedback. Now in the intervention group, the residents had to allow notifications. So for those of you who have iPhones, you know what I'm talking about. It's the same process on the Android system. And you have to, install the app, you have to allow notifications. And we had one additional feature, which is very important. In order to track whether you actually looked at cases and completed the questions for that case, you had to enter a unique ID number. So for example, if you were a resident at the University of Alberta, you were assigned this number, let's say John Smith, Alberta, you were assigned this number, you had to enter that into the app. That was called signing in. And when you did that, we could track what you did, okay? I'll come back to why that's important later. Here's the first type of alert. We actually send 2 types of alerts. But every Wednesday afternoon at 12, high noon, you'd get a bing. And the bing said, you've got a new case. And if you wanted, you would touch the alert, and then you'd be able to see the new case of the week. And so we started doing that when they were first-year residents in January of their first year. And we did that every week until their exam in April of the second year. And that was 67 weeks. So in theory, if they had followed the alert to the case of the week, they would have seen 67 cases in the app. And the control group had the app, but no alerts. So they could use it whenever they wanted to, like a book sitting on their desk. And that's the comparison between the intervention. Oh, we did one more thing. We sent a second type of alert. So if you did complete the questions for a case, you were then asked the following: are you satisfied with your answers? If you said, yes, I'm satisfied, you were sent this second type of alert here to review your cases 2 weeks later. If you said, no, I'm not satisfied with my answers, you were sent this second alert to review that case, to review the questions of that case 1 week later. So it was an adaptive algorithm depending on whether you were satisfied or not. And that's all in line with how prior trials of spaced education have worked. So in summary, if you felt your answers were largely correct, you would get a second alert 14 days later. And if you said you did the case again, you said my answers are correct, we would stop sending an alert for that case. If you said, no, I'm not satisfied, you'd get an alert 7 days later to repeat the case and try the questions again. Okay, so that's how the algorithm worked. The primary outcome was the score on the 2019 certification examination of the College of Family Physicians, and our power calculations were based on detecting an increase in 4 percentage points, comparing intervention versus control. This is an exam that you can score from 0 to 100%. 50 test questions, that's the short answer management problem section on the certification examination. We did a secondary, we had a secondary outcome, and that was the number of clinical cases that were completed by participants in each group over the 16 months of the intervention. And this was a mechanism by which we could explain an improvement in test score, meaning if you did more cases, that means you engaged more with the content and you hopefully learned more. So this was a theoretical mechanism by which it could explain the outcome. So I'll get quickly to the results and then we'll have time for discussion. We approached 13 sites in Canada. As you know, there are 17 schools based in universities, 17 residency programs based in universities in Canada. 12 agreed. 2 of them were French, Francophone universities. Université de Montréal and Université de Sherbrooke agreed. Okay, so we had 2 Francophone, 10 Anglophone. They were randomized by size. So the number of first-year residents, it was a stratified randomization. And so 6 intervention sites, 6 control sites. Now you remember when they had to put that little ID code into the app in order for us to track their completion of cases? Well, unfortunately, about a quarter of them didn't do it. Even though they said they would, they consented, they were informed, they were harassed, they didn't do it. So we lost about a quarter of our residents right there. So that is one lesson I learned right away for the next time. I'll tell you more about it out. Having said that, we were able to track quite a few of the residents. So at the 12 sites, there were about 1,200 residents that were eligible. We consented half of them, so over 600 residents, split roughly 300 to intervention control. About 134 never signed in, but that left 500 who did sign in that allowed us to track. And of the 500 who said, yeah, you can track what I'm doing in the app, 381 completed at least 1 case. So far, so good. This is what a family medicine resident looks like in Canada, typically. They have a median age of 27. There's 70% of them are women. And 70% of them use iPhones, not Android phones. I mean, this is pretty balanced as randomization goes. There was a slight difference in terms of the number of international graduates in the control group, but overall balanced. Now, I'll just show you what about completion of clinical cases. This is the total number of cases completed during the trial in the leftmost column. So what we're seeing here is that, doing nothing was actually a little less common in the intervention group. So we're seeing a small effect of the intervention if you look at it this way. They were more likely to do 80 or more cases in the intervention group compared to the control, and less likely to do nothing. But then I went to Tibor, and he was able to do some really fancy analyses. And what we're looking at here is a difference curve. We're looking at the difference in weekly cases that are completed per 100 residents. So effectively, this line here is intervention minus control. And this red line is 0 or no difference. And you've got confidence bands, 95% on either side. So really nice work. And what you see here is, yeah, there is an effect of the intervention up until about day 300. And then actually at the end, the controls are doing more than the cases. But at no point does the lower confidence band rise above the 0 line. So although we're edging on significance here, we didn't quite reach statistical significance. So, in the end, you can't say that there's a difference between the two, although obviously there's a trend. Punchline, no difference in exam scores. Okay. Intervention group 74, control group 73, about 1% difference. A standard deviation was much less than we thought it would be. So even though we lost residents, we don't think there was a type 2 error because the standard deviation around the mean was about half of what we actually expected. So our expert thinks we had enough statistical power. This is a per protocol analysis. What that means is if you followed the instructions and you signed in to allow us to track your use of the app and you wrote the exam at the expected time in April of your second year, in the intervention group, we see kind of a weak positive association between completing cases in the app and exam score, sort of weekly positive line. Whereas if you look at the control group, it's a weekly negative line. So comparing the two, there is a statistically significant difference in the slopes of these two curves. This is intervention, this is control. In the per protocol analysis, not intention to treat analysis. And what this means is that, again, there's a signal that if you follow the instructions and you participate the way you were supposed to, it's like if you take the drug in a randomized trial, then you actually see an effect. Okay, interpretation. A couple of things to say here real quickly. Number one, although this glass is half empty, I see it more like half full. Why is that? Why am I positive about this? I'm positive because, for one thing, we pulled off a national study of an educational intervention. We showed that we can do it, and we can do it again if we have to. If we want to, we will do it again. But to my knowledge, this was the largest RCT of an educational intervention in Canadian family medicine. If you know of a different one, a bigger one, please tell me. I am unaware of any, and everyone I speak to is unaware of any. And so it's a kind of a proof of concept that we can do these large trials around important educational questions. So in that sense, it's really a positive outcome for me. Unfortunately, it's not the definitive answer. There are still people out there who will believe that spaced education works. It works in family. It should work in family medicine because it works in urology and oncology. And what's the difference anyways? Family medicine's all the same with the other specialties. There's no difference. That's a provocative statement that I don't agree with, but I've heard people say that. So we had limitations. Education is all about attention. This is an actual web page on our department's website, okay? And it was put up at the same time in 2017, 2018 that I was running my trial. It was put up as a way for residents to prepare for their exam, and it's in direct competition with the intervention that I was testing. So I didn't try to be exclusive. I didn't claim I want to do something that no one else could, like you can teach residents any way you want to. But all that to say is that the context here is that I was competing for their attention with other interventions that were happening at the same time. And that competition was hard to compete with. How could we do better? I mean, if we had more organizational support, I mean, if the departments said, we have this intervention, we really want to test it, we're going to talk it up we're going to, support it and not compete too much with it in terms of giving them alternatives to, to use, then we might have a better chance of actually, stimulating residents to use the intervention we're trying to test. So a couple of, practical things. If we had locked the app until the participants signed in, we would have had fewer losses to follow up. But that wasn't consistent with the idea of this being a pragmatic RCT. It was pragmatic in the sense that we didn't put conditions. We didn't have a run-in period. We didn't say only people who really want to use the app can participate. I mean, we offered you the app and you said you wanted to use it, and whether or not you used it, that's a pragmatic issue. So we didn't do it like a drug trial where you do a run-in period, and if you don't take your drug during the run-in period, or if you have a problem with the drug, then you don't get into the trial, right? That's not a pragmatic approach. We had a problem about tailoring alerts to match the clinical rotation of each participant. So if you were doing an obstetrical rotation and you'd get an alert to a clinical case about an 85-year-old person, I mean, that's not exactly relevant to what you're doing right that day in obstetrics. So we have this challenge in family medicine of matching the relevance of the alerts to what, hundreds of different residents are doing in a dozen different specialties. So it creates a real logistical challenge in that way. Some people claim we shouldn't have used the exam as an outcome measure because the exam is too far in the future. It's like 16 months after you started your intervention. There's such a high motivation to do well on the exam that the control group is going to study so much compared to the intervention group. It would be hard for you to actually find a difference. Valid point. I'd love to have a better outcome measure. And Charo, I'm pretty much done, but if anyone's interested in hearing more about this trial, the Keyline podcast, episode 300, covered this just a couple weeks ago. They said some interesting things. Some I agree with, some I disagree with. And there were absolutely some factual errors in their reporting of the trial. They made some factual mistakes, but having said that, if you're interested, this would be something to listen to. So I took 40 minutes. Sorry about that.
Don't worry. Thank you so much for this excellent presentation. Very compelling as usual. But first, I remind you that this seminar is being recorded. So if you want to close your camera, obviously you are free for doing so. You are allowed to do so. And then close your micro after the questions. There are two on the chat. Maybe we will start with this one and then we'll open the discussion to other people. And Roland, if you can remove the presentation, then I think it will be easier to see the faces of people coming here. So maybe, Anne, you could start. You are the first in the list. Would you like to ask your question yourself?
Yes, thanks. Roland, I may have misunderstood. I thought you said there were about 1,200 and you consented about 600 of them. So I was wondering, why did you only consent half of them, and what was the story with the other half?
They simply didn't want to participate in the trial.
Oh, okay, I see. No, I understand. So they were invited, and I didn't realize that. Okay, thank you. That's clarified it. I was just puzzled on what basis they didn't do it. It was just because they didn't choose to.
I assume so. I mean, it's tricky to reach these people. As you know, they're training in hospitals, some of them in clinics, but many of them are doing hospital rotations. They come together at academic half days, like once a week on a Wednesday afternoon. But, in any one time, someone is away on vacation, someone is sick, someone is post-call and is not there. And so you try to reach all these people, but it's not so simple. So we were actually pretty happy that we were able to get about half of the sample, and I thought that was pretty good. We did it, again, we did it without special organizational support. And what I mean is, I went to these sites. So I called someone I knew at the University of Alberta. I called someone I knew at the Memorial University of Newfoundland, UBC, Sherbrooke, Queens. And I'm calling these places and I'm saying, look, I've got this idea for a trial. And by the way, I see Vanita D'Souza on the video, and I just want to thank her so much for helping me do all of this. Christian Rouchon helped me as well. And so we reached out and we said, look, we have this trial. Would you be interested? And they said, yes. 12 out of 13 said yes. And then he said, well, how are we going to recruit the residents? And I had to leave it up to them to do their best, at their individual sites.
And did some of the sites do a lot better than others in terms of recruiting people?
Yes. Recruitment at Université de Montréal, for example, was not high. It's an English app. Maybe that had something to do with it.
Right. So it wasn't even across them. There were some that recruited a lot and others that not so many.
Correct. There was variability. Yeah.
Interesting.
There was.
Interesting. Thanks very much.
Thank you, Anne.
Thank you. Now the second one is Fanny, it's your turn, and after Alex.
Well, I guess I can read my question, Roland. First of all, I want to really thank you. I think this is really excellent work. I'm really proud that you're part of our department and that you're really moving this forward throughout really Canadian postgraduate medical landscape. And I have to say, I was so impressed, and I really wish that more of our department would know about what you're doing. So, so my question has to do with, did you have any qualitative data? I know it wasn't a qualitative study about whether those residents who were part of the study would use this app rather than, for example, using another resource, or at the expense of using another resource, such as the resident study guide, or would they use both of them?
Good question. I mean, so back in 2015, 2016, I approached Charo to do I wanted to do a qualitative piece alongside the trial to find out, if the intervention did not work, what could we understand from that? And CIHR is not really interested in funding research when the outcomes are examination scores. Even though there's a correlation between examination scores and future performance in practice, there's an association there that Tamblyn showed. They don't see that as being their mandate. So I went to the Royal College. The Royal College has an annual competition. And I applied on 2 consecutive years for funding, and we were not successful, even though we had good scores. One of the criticisms of our work was that we weren't proven as a team. That's what they said. We're not proven. Well, now we're proven. So if we could go back to them, we would probably get a grant, if I had the energy to do it again. The question is should this trial be repeated? That's another question we could debate. I think it's worth debating that question at some point. And so if we had done qualitative work, Fanny, we could have answered your question, I think.
Yeah, I mean, I would think that different schools have different resources at their disposal. And, maybe some of them are better than others. And especially now, even a few years later, there's so many more, online resources that are being used that it might be hard to tease out which is having an effect.
It would be hard. And so, if we're going to debate that question, is can we do an intervention to improve examination scores? The question then becomes, if you're competing with so many alternative if people are studying hard for the exam anyways, and they're using other things anyways, how much stronger can you make them? Through the use of a learning strategy like spaced education. So there could be there could be kind of some sort of logical problem that I have to kind of work out in my head there and ask myself, does it make sense from a logic point of view,
Thank you so much. I would add that CIHR is particularly difficult. It's particularly difficult that CIHR funds medical education studies at large. As you have said, Roland, I think even if there are some committees that consider or include in their expertise medical education, health profession educations, I agree with you that it's not very usual that they consider medical education, health profession education as part of their mandate. So definitely we need to look for agencies or submit to agencies other than CIHR for this type of study. Now is Alex. Alex, you raised your hand, so please go ahead.
Yes, I just want to wonder, like the alert was set at on a Wednesday at lunchtime, and I'm wondering if you considered if that could have an effect, either using random alerts or a self-selected time or a time in the evening where the resident could be more ready to kind of decide to study. Do you think that could have played?
Yeah. Good question, Alex. I mean, it's a question of tailoring. I mean, could we tailor the intervention to better meet the individual who was receiving the alerts? So you could imagine tailoring based on time of day. You could imagine based on clinical rotation. You know, I'm on this rotation. I don't want to receive alerts this month, or you know, I want to receive more alerts because I'm on a different rotation. These are unanswered questions. I think tailoring makes sense. The problem is that it requires a level of technical expertise and funding that we didn't have. As you know, I funded this through my own money, unrestricted money that I get from Jewel through the CMA, essentially. I have a very limited grant from them. So I was able to scrape about 50,000 together to do the trial. And that got me an intervention version of the app that I was satisfied with, but it's clearly it wasn't. I don't think it was enough. It wasn't tailored at all, and so I think in that sense we would need a bigger budget. We did notice, by the way, we did some analysis. Actually, Tibor did this by day of week. So on Wednesdays, when they got the alert, they were about 5% more likely to look at the alerts on Wednesdays, comparing intervention versus control. Control was more likely to look at the alerts on Sundays. So it's, you know, I could shift their behavior, and I could increase their ability. I could increase their look. I could increase the number of times they looked at the content, but only a little bit. And towards the end of the study, as they're getting right towards the exam, the control group actually passed the intervention group in terms of looking at the app. So, you know, I think maybe surprised at how much the control group residents actually use the app.
They freaked out before their exams.
It's a pretty strong motivator, and I could see that. I could see that in the use of the app. Absolutely.
And also maybe they hadn't looked at it before, so they had more sort of fresh cases to look at. So I guess maybe at that point.
Yeah, I mean, it's no question that, I mean, the external motivation of having to pass your certification exam is a super strong motivation. And can any educational intervention improve outcome in that context? Maybe maybe we're talking about the wrong outcome measure. Maybe I shouldn't be looking at the certification exam. To be honest, it was appealing as an outcome because it's there. The data is collected. You know, it's not hard. It's an exam that's been around for decades, and it's guaranteed to, you know, the data is guaranteed to be there. So it's so appealing in that context. But when it comes to an educational intervention, maybe the next time I would have to do something like this. Instead of doing it over 67 weeks, I do it over 10 weeks, and I have to create my own exam. And, you know, I have to administer that exam to intervention and control. And I don't know if you've ever tried to write an exam and prove that the exam measures what you think it measures, but it's something I've actually done in research funded by CIHR 17 years ago, I did that, and I'm not sure it was a lot of fun. We did it. We published this. We published our data on it. But creating an outcome measure is it's like saying, okay, you're going to grow the wheat, you're going to harvest the wheat, you're going to bake the bread, you're going to sell the bread, and then you're going to evaluate whether the customer likes the bread. You know what I mean? It's a pretty tall order to do all of that.
Thank you, Roland. Fanny, I have seen that you have written along this in the chat. There is something else that you would like to comment, or you have already said anything that you wanted?
No, it had to do with Roland. You know, the way we structure our curriculum in the 2-year program is this longitudinal, where the residents, it's a bit of a hybrid, because you could either have a program where the residents just rotate. They rotate through pediatrics, they rotate through outpatient, they rotate through inpatient, and it's very like vertical. And then you have where you have some vertical, but you also have the horizontal aspect where you have your own practice that you follow as well throughout the 2 years. And then you have the other model where it's really mixed in, you know, really integrated, where you're doing everything at the same time. And so when I'm thinking about spaced education, there's not the testing component as much, but you're being faced with the same information repeatedly. So either if it's just a vertical type of curriculum, you're being faced with it during that period intensely, or if it's really integrated, you're being constantly faced with the same information throughout the 2 years. And I'm wondering if there's been a comparison in terms of the, you know, the outcome, or what the outcome measures are when they're comparing those types of curriculum design.
Yeah, it's a very interesting question. I've always wondered, you know, why Western does it differently. And to my knowledge, no one's ever evaluated it. So compare McGill with Western, right? Fanny, you may correct me if I'm wrong, but Western, you know, used to do family medicine blocks 6 months long. So when you did a continuous 6-month block of family medicine, and then you did 18 months of your specialty rotations, and you didn't come back to family medicine. So there wasn't that half day back. That's model Western. Then you got model McGill, and no one's ever compared, you know, the two in terms of outcomes. I'm not sure if that answers your question, but to my knowledge, no one has ever done the kind of work that you're talking about, you know, to compare outcomes among two different models of training.
We think it makes a difference. Intuitively, it seems to make a difference. Well, we think, we don't know, right? Because we don't know what we're measuring.
You know, I think that's the basis for medical education research is something like this. Teaching is good. We know we got to teach, right? If we teach, they will learn. But how do you learn them better? You know, how do you do better? And the question is, what is better? How do you measure what is better? So these are the fundamental, I think these are fundamental questions that we have to address. At some point, you know, medical education has to address. It may not be in the context of really big trials like I just pulled off. I mean, this was a big trial, 12 sites, over 600 residents. That's not maybe the kind of study you need. Maybe you need a smaller study that looks at some more proximal outcomes, you know, not at the end of residency, but during training, and doing a smaller, simpler trial. I would still argue that a trial would be good. And I would still like to get Charo involved and do qualitative work alongside so I can better understand what's going on.
I think it would be interesting to actually do a pilot, like in one of our Montreal sites, where you try to compare over 6 months that integrated, you know, they might do a week of wards and then a week of OB and then, you know, clinic compared to what we have now. I mean, I think it's a huge project, but like, I think that would be interesting because I think you're comparing about apples and oranges if you're comparing a site like Val d'Or, where that's the way rural practice functions, to a site like Montreal.
Yeah. And we also don't have any in training assessment, as you know, apart from the, you know, the ITERs, the subjective in training evaluation, which I guess, you know, I'm a bit of a post-positivist guy. Like I like numbers, and I get some comfort in numerical assessments, but I think assessing a family medicine resident and their ability to practice is something much more complex than just an examination score. And this is where we would have to figure out what kind of evaluation we could do, because I'm not sure that just a numerical assessment would be sufficient in today's world, where we understand that training is very complex and an exam may not capture the outcomes that you're looking for, all the outcomes you're looking for.
Terrific. There is 2 minutes left. There is any other question that anybody would like to ask? Yes, Juan Pablo, go ahead.
Thank you. It's regarding the baseline disbalance regarding the proportion of international medical graduates. I was just wondering if you think there could be an impact of that disbalance in the result or not.
Yeah, thank Juan Pablo. So, one fact, at least based on research I've seen, that could be several years old now, but is that the international graduates do score lower on the short answer management problems. And my outcome measure was the examination score. So if there was an imbalance, it could bias the results in one direction. In this case, in the case of this trial, there was no difference in score, no meaningful difference. There was a slightly more IMGs in the control group, which could have lowered their score, but in this case, I think it was irrelevant.
Thank you.
Okay, I think is everything for today. Thank you so much, Roland. It has been a fantastic presentation. I'm sure that if you conduct again this project now in the hopefully post-COVID-19, you will have more participation. Maybe, I don't know. It's something that has come to my mind, because now I think with this the use of information technology of any level at any level in medical education and health professional education is massive now, and maybe you could have more a participation rate that could be higher. I don't know, but I encourage to conduct. I think you and your team, you have been terribly courageous to conduct such a big randomized control trial, extremely interesting, and courageous too to publish non-significant difference and results that I think we all have learned enormously with that. And I really hope that the next time that you will conduct a randomized control of this scope, the qualitative part will be more present, and we will be funded with that. Anyways, thank you so much again, and thank you everybody for your attendance. For the current academic year, the FMER advanced seminars are over. Maybe we could organize something special at the end of the academic year, but we are already planning the seminars for next year. Thanks again for attending this event, and it has been very, very nice to see your faces, because being on sabbatical, I don't see you even not through the screen. So take care and have a nice afternoon, everybody. Bye-bye. Bye, Roland. Thanks a lot.